Hello, everyone, and welcome to today's webinar titled PIV Failure, Why a New Standard of Care is Needed from the Association for Vascular Access and sponsored by Adhesion Biomedical. My name is Eric Sager, AVA Director of Communications, and I have the pleasure of introducing today's speaker. Russ Nassoff is an attorney with more than 25 years of experience in clinical healthcare and environmental risk management, advising clients worldwide on liability and risk minimization for emerging issues. He has owned and operated 3 major consulting groups, one of which was sold to a public company, and is an active presenter and educator on reducing risk and liability for vascular catheter-related issues and healthcare-associated infections. He has been instrumental in introducing legal and risk management issues to numerous healthcare organizations, including ASHRM and APIC. We also have Judy Thompson, AVA Director of Clinical Education on the line, who I will hand it over to now.
Hi, everybody. I want to welcome you today. As Eric just mentioned, our webinar today is sponsored by Adhesion. So without further ado, I'm going to turn this over to our friend Russ Nassoff, who will take us through our presentation today.
Thank you, Judy. Great, thank you. I would like to thank AVA for sponsoring another educational webinar. Hopefully everybody's finding these to be helpful in their day-to-day practice. And I would also like to thank Adhesion for sponsoring this webinar. This topic that we're going to be talking about today is actually one of my favorites. It's one of my favorites for a few reasons. First reason being that it's a fairly simple topic. I know many times you go to these lectures and we talk about very complex clinical things which are way beyond my comfort level, things like vessel ratio and other complicated things. This webinar is actually about a very simple topic, stability and securement. It's so simple that they allow a lawyer to do it. And what I always tell people is the hardest thing about this concept that I'm going to be talking about today is actually saying the word cyanoacrylate. So once you can say the word, you pretty much will get the concept. The second thing that I really like about this webinar is I get to talk about my favorite topic, which is peripheral catheters. And those of you who've heard me talk before know that this is one of my favorite topics only because I really believe that is one of the most under-recognized and underappreciated risks in healthcare today. And we're going to be talking about tissue adhesives specifically with respect to peripheral catheters, but please keep in mind that while my focus today is going to be on peripheral lines, that the issue and the product and the solution actually is applicable to all catheters, but our focus is really going to be on PIVs. And fortunately, we are seeing more and more knowledge and awareness about PIVs. We have seen a lot of good studies come out recently, and we're going to be mentioning some of these in my presentation today. So just a couple of my disclosures before we start in with the presentation, and then we're going to go into some of the objectives. And we all know that our catheters, and specifically our PIVs, are failing. And one of the reasons, among others, that they are failing is because of a lack of stability and securement. And Judy, I think now, before I even get further into the objectives, let's do the first polling question.
So which adverse events are most prevalent at your facility? List all that apply. So phlebitis came in at 46%, occlusion thrombosis 32%, infiltration extravasation at 78%, dislodgement 50%, and infection at 13%.
Interesting. So we're going to be discussing all of those complications today, but clearly that's in alignment with much of the research and much of what we've been seeing. So we know that at least one of the causes of these adverse events is the failure to stabilize and secure the catheter. And it's also important that we consider solutions to that problem. And what we're going to be discussing during this webinar today is how do we develop solutions to that problem? How can we implement solutions to the stability and securement issue using the legal argument? And legal arguments can be very persuasive, not only with respect to stability and securement, and not only with respect to PIV issues, but with respect to all issues. And people who are looking to implement change and become what I call the tall poppy might consider using the legal argument to help implement and change practice and product in your facility. So we're going to be looking at how do we meet that evidence-based standard of care? Do we need to just follow the guidelines, or can we feel comfortable implementing an evidence-based standard? And if we can implement the evidence-based standard, does tissue adhesive in fact meet the criteria for the evidence-based standard of care? And lastly, we're actually going to look at whether the failure to implement a solution which meets the evidence-based standards, such as tissue adhesive, can actually constitute negligence and potential malpractice in your environment that you work. So it's what I call the affectionately neglected catheter, the PIV. I think that everyone realizes that this is the most common catheter we have. And everyone also knows that it's also the catheter that receives the least attention. As a matter of fact, there was an article just published a few months ago by Tetsuno in which he calls the peripheral catheter the safe catheter. In my opinion, the perception of this catheter being safe is one of the problems surrounding this catheter, because we really don't feel that it can cause any problems. Yet this is the same catheter that clinicians really don't feel comfortable inserting or maintaining. So when JAMA did their study a few months ago, they found out that in fact PIV therapy was one of the top 3 skills that even graduate nurses felt uncomfortable performing. And even experienced nurses expressed a lack of confidence in their PIV catheter skills. And most nurses, even in nursing school, never had the opportunity to insert a catheter. And is the reason for this because we just don't feel it's very important? We don't feel that it's very significant to the well-being of our patients. And is it because, as you've heard me mention before, this name, the nomenclature, peripheral, actually implies a lack of importance? Is it because we don't have a clearly defined intervention bundle? Is it because it's not tied to reimbursements? Is it because it's not even recognized as a source of infection when we've got a central line present? So the PIV is not treated as a potential independent source of infection, at least in most cases. So all of these things may be contributing to the fact that we really don't give this catheter, in my opinion, the respect that it deserves. Robert Helm, in his article, Accepted but Unacceptable PIV Failure, was really one of the first in the country to recognize that our PIVs were failing. And he brought up the staggering statistic that we actually sell over 380 million of these in the United States, with 175 million placed and billions sold in the world market. Yet the majority of these catheters fail before their anticipated therapy is completed. It's really kind of a shocking statistic. And while the incident rate of things like infection is low, when we look at the numbers, the actual numbers turn out to be huge. So even though the incident rate is low for infection, this amounts to over 500,000 infections. And as you mentioned in your poll, we also have problems with infiltration, extravasation, 35 million of those, 12 million dislodgements. As a matter of fact, the PIV is the most commonly dislodged catheter, and many studies show that infiltration is one of the most common problems associated with the PIV. So clearly there are problems occurring with this catheter. Judy, I think it's time for the second polling question.
So do you feel stability securement issues for PIVs is a major factor for PIV failure in your facility? 71% of you say yes.
So that's interesting for us to see, and certainly a reason why we're going to be focusing on this issue. So if so many of them are failing, why isn't anybody looking? Why is our data on PIVs so poor? Why are the infection rates only stubbornly decreasing? And are we overlooking our biggest issue? And as I've said before, many of you've heard me say this, the lawyers don't care what you call the catheter, the bugs don't care what you call the catheter. An infection is an infection, and in law, we have something called equal treatment of equal risks. The PIV can be responsible for an infection just as well as any of the other catheters we insert. And so the question then becomes, why don't we require maximal sterile precautions for the PIV when we require these precautions for virtually every other line that we have? Judy, post the third question, please.
Okay, guys, do you feel sterile precautions should be used for PIV insertions? We're getting up there, almost to a 75%, which seems to be my marker today. And let's close this and see what people say. 70-30, Russ.
70-30, yes?
Yes, sterile precautions should be used.
Okay, and I know that there are issues with requiring that, but I want you to understand that there are potential legal ramifications and legal arguments that can be used in this arena as well. So are we starting to see a change? All of you seem to say that we know the PIV is a problem. Are we starting to see a change? Well, several years ago, Mermel actually published a very interesting article in which he identified that a third of all Staph aureus infections were actually, in his study, were actually related, or the source of them was the PIV. In the state of Pennsylvania, a state that requires the reporting of all infections, they've actually found that PIVs were the leading source of Staph aureus infections in their hospitalized patients. And Shea has finally come around to the realization that the PIV can be a source of infection independent of the central line. So maybe things are starting to change. And the question then becomes, how do we make the changes and improve PIV practice? And do we need a new standard of care around PIVs? ECRI, thanks to the work of Marcia Ryder and Beth Gore and some others, finally this year acknowledged that the PIV issue is actually one of the top 10 patient safety concerns out there. So we're starting to get a little recognition. Unfortunately, the photo on the right showing the IV in the hand is not exactly the best photo that maybe they could have used with respect to insertion location. Nonetheless, we're very glad that people are starting to become more aware of this issue. So where do we look for answers? Well, we need to look no further than photographs like this. And we know, for example, the photograph on the left, by the time the dressing looks like this, it's already too late. Whatever adverse event is going to occur has probably already occurred. And when we look at the photograph on the right, we know that patients' arms should never look like this. Unfortunately, most patients don't understand that something like this is not really a normal situation. But I can tell you, based on what's happening in the litigation arena, because of the simplicity of this issue and because of the fact that it's so easy to see when there are problems like this, lawyers are beginning to become aware of the stability and securement issue, and these photographs are showing up in court. So what do we need to do? How can we keep our catheters in longer? What can we do to keep the catheter performing successfully over its intended duration? Well, one of the people we need to ask for that question is our friend Dr. Jack Ladon, who's always told me we spend way too much time focusing on insertion, 1% of the life of the line, and not enough time on the care and maintenance. And so if you ask Dr. Jack, hey, what do we need to do to make these lines last longer? Well, we need to be sure they're made of biocompatible materials. They need to be inserted sterilely, maintained pristinely, accessed aseptically, take them out when they're no longer needed, put them in the right location, not in the hand or the wrist or the anticube, make sure they're put deep enough in the vein, and then you've got to stabilize and secure them. That's what we need to do. And it's very important that if you're creating a bundle around the PIV, that you include every intervention that could be important in that bundle. And if you're thinking that stability and securement is not a particularly important intervention, I will remind you that your bundle is only as good as the least important of your interventions. And if you're not complying fully with every single intervention in the bundle, you might as well not have a bundle at all. Judy, can we have the fourth polling question?
Happily. Does your facility validate competency on PIV insertion? Results are coming in similar to our survey, Russ. So 49%, no, my facility does not validate. Then another 38 only when hired, 13% hired and annually. Gosh.
So, and this validates the Java survey, actually, that was done.
Does.
So when we look after insertion to care and maintenance, we're looking at stability and securement. And I find very interestingly that many times people don't even understand the difference. And securement means to anchor. It's not the same as stabilize, which means to keep the catheter from rocking back and forth. Both of these issues can be potentially problematic. I use the analogy of being on a boat if you get seasick. If you're not anchored, you can be wobble, you can have problems with seasickness. And if you are anchored, but you're bobbling in the water, rocking back and forth, you can also get sick. And we know that both stabilization and securement can cause problems, as was identified in the first poll that Judy did. If we damage the vessel, we can get phlebitis, and we know that phlebitis can be caused by infectious as well as inflammatory means, but we're going to be looking at it from a mechanical standpoint, a mechanical cause of the problem. We can also get thrombosis. If we get a perforation of the vessel, we can get an infiltration or an extravasation. And lastly, we can actually get a dislodgement or a catheter movement out of the vessel itself. And as I said earlier, while we're going to be focusing on PIVs, this is applicable to all catheters. And sadly, this little girl, Emmy Gunther, sitting in Stollery Children's Hospital in Winnipeg, Alberta, knows all too well about the failure to stabilize and secure a catheter. This little 3-year-old underwent open heart surgery a few months ago. The surgery went very well. She comes out of surgery with an IV, and she's fussing. She's not happy. Obviously, it was a big surgery for a little kid. Her parents just assumed that she was fussing because of the trauma of the surgery, not realizing that there may have been a problem with her IV. She's fussing all night. They call the doctor. The doctor never shows up. They call the nurses. The nurses check on little Emmy, but they never look at her catheter. In the morning, when she's still fussing, and they go to look at her bandage, which is now soaking wet, and they take the bandage off, they find an extravasation, which is a picture of her little hand on the left there. What makes this case particularly problematic is that Emmy is a nonverbal communicator. She may have lost the use of this hand, requiring 2 extra surgeries and 2 additional weeks in the hospital. And as we conclude this presentation, we're actually going to come back to Emmy Gunther and what's going on with her currently. So why are we always putting these things where they don't belong and then wondering why they move around and don't last? Why are we surprised when we don't stabilize and secure them that they're going to move? Well, if we look at the guidelines, they do tell us to use the site that's most likely to last the full duration of the therapy. They tell us to use areas like the forearm and the upper extremity. They tell us not to use the wrist and the anticube, but what do we find? More times than not, the IVs are in the wrist. The IVs are in the elbow. The IVs are every place they're not supposed to be. And why is that? Because it's easy and because we can see the vessel. But these places are also 2 to 3 times more likely to result in infection. So Judy, let's take a look at poll question number 5 with respect to location.
In adults, how often do you see PIVs in improper locations, i.e. the foot, thumb, breast, abdomen? It's pretty even Steven out here. Commonly 16%, frequently 30%, occasionally 33%, and 21% say rarely. Very good.
Very good. We know if we put them in the wrong location, that we can have a lot of negative outcomes. We're going to have to restart the catheter. It's going to cause pain, potential pain and anxiety for the patient, increase the cost of care. We increase our risk of infection. We definitely have a risk for reinsertion, and we have potential liability and a failure to meet the standard of care. We talk about the standard of care. Remember, it's the caution that a reasonable person in similar circumstances would exercise in providing care. I say this all the time. You can be wrong, you can make mistakes, but you can't be negligent. So the question then becomes, are we meeting this standard of care when it comes to PIVs? We've got to look to the guidelines to see, are we meeting the standard of care? We can also look to evidence-based practice, but we need to remember that the standard of care is rarely 100% evidence-based. But just like in court, the stronger the evidence, evidence-based, the greater the likelihood that you're going to prevail on the merits of the case, the greater the likelihood that you're going to have a positive outcome with respect to your patient. So what is that standard of care for PIVs? Well, some of the things we consider, number one, cleaning the site prior to insertion. So clearly skin antisepsis. Why? Because we're going to puncture the skin in the vessel wall, creating a wound. That wound is going to ooze. So we need to protect that puncture site from the organisms that are so common on our skin and that can cause infection. Then we've got to stabilize that catheter. We've got to prevent the micro motion or pistoning of that catheter. We've got to cover the site with a dressing. We know that the less often we disrupt dressings, the more likely we are to have good outcomes. We want to protect the integrity of the skin, prevent things like MARSI, and of course, we want to reduce the opportunity of infection. So we want a product, we're going to look for a product that's going to help us meet those standards of care. Because we know if we don't meet the standard of care, we can damage the vessel, as I've mentioned before, phlebitis, thrombosis, we can damage the skin, our catheters can fail, and we can get infections. So simply stated, the devices have to be secured, the dressings have to be kept clean, dry, and intact, but the problem is we know that our dressings aren't lasting, our catheters aren't being stabilized, and a recent article by Way that just came out a few weeks ago says that most PIVs are failing within the first 36 hours of dwell time. So we know that not only are they failing, but just like with little Emmy Gunther, they're failing quickly. So where do we look for answers? Well, the first place we look are the guidelines. And we know that in our quest to moving to the gold standard of clinically indicated removal, we need to look to the guidelines. But the guidelines really don't give us a lot of good information or a good roadmap with respect to how to get there. They say consider the use of engineered stabilization devices. So they do say we need to stabilize and secure. We shouldn't use tape or bandages. We shouldn't use our dressings to stabilize our catheters, and be aware of skin injury. Judy, would you post the last question, please?
Happily. For adult patients, when do you remove and replace your PIVs? And clinically indicated is at 70%, followed by 72 to 96 hours in PRN at 23, and then 7% of our folks are going 48 to 72 hours in PRN.
That's really excellent. That's very good. We've got a lot of good clinicians on this webinar. So when we're looking for answers, the first place we tend to look are the guidelines. And guidelines can be problematic. The main reason guidelines can be problematic is that they may not be current. Guidelines can be based upon professional consensus. They can be based on customary practice. They can be based on just kind of what we've always been doing. And in healthcare, we hear that all the time. This is how we've always done it. Well, the problem with guidelines is they may not be current. In addition to that, it takes a long time for guidelines to change, and very often by the time the guidelines are published, technology has already passed the guidelines by. In addition to that, the developers of the guidelines may in fact also have certain biases for certain products, certain technologies, which can enter into what is actually published and the guidelines that are actually followed. But most importantly, there is this requirement to keep current. And this requirement to keep current in law actually came about not from anything in healthcare, but from a 1937 case where two tugboats pulling barges of coal had left the port of Virginia, the T.J. Hooper and the Montrose. And these tugboats were pulling this coal up to New York. And a storm hit and blew all of the coal into the sea. As you can imagine, the coal owners weren't very happy, so they sued the tugboat owners for the value of the coal. The tugboat owners said, hey, you know what? You can't blame us. This was a storm. This was an act of nature, an act of God, and we're very sorry it happened, but you're not going to get your coal back. Well, unfortunately for the tugboat owners, there were 4 other tugboats pulling coal that left Virginia that same day. They all had radios on their tugboats. They knew about the storm, and they safely docked the coal in Delaware, thereby saving the coal. This was the beginning of the court's recognition of the need to keep current with technology. The most important case with respect to this concept relating to healthcare happened in 1990 when Laverne Thompson checked into Washington University Hospital for an abortion and a tubal ligation, a simple procedure that went horribly wrong when they put the endotracheal tube into her esophagus as opposed to her trachea, causing her to arrest on the table, leaving her in a vegetative state. The notes during the surgery noticed that her blood looked unusually dark during the procedure, indicating there was a lack of oxygen. Her husband decides that he's going to sue the hospital. And the basis of his lawsuit was that Washington Hospital should have had continuous oximetry monitoring on his wife during the procedure, because they then would have known about her oxygen depletion and would have been able to save her or to prevent the adverse events that happened. The hospital replied that this was 1990. There were 2 or 3 white papers written on this concept of continuous oximetry monitoring, and only 2 or 3 hospitals in the entire nation were using this little device at this time. However, the court ruled that the defendants were liable for medical malpractice because they didn't adopt the technologies and procedures that were out there, even though very few other hospitals were using it at the time, even though no randomized control trials were out there on continuous oximetry monitoring at the time, and there were only these small evidence-based studies on which to go by. This was the first medical case, or one of the first medical cases, indicating this responsibility to keep current, this duty to stay abreast, this concept that I talk about all the time, that if the guidelines are outdated, compliance is not going to excuse poor practice. And this isn't to deflate the value of the randomized control trial from the Hopkins pyramid. If we've got randomized control trials, we need to use them. This is the most important evidence we have. But all too often, these RCTs take a lot of time. They cost a lot of money. And we could be missing out on great opportunities waiting for the results of RCTs. So if there are good, small, evidence-based studies out there, you need to be aware of them, and you need to feel comfortable that you can use them and that you should use them, because the failure to use them may actually set you up for potential liability. And then we get to the Sackett model of evidence-based medicine. Now, we've already talked about the importance of keeping current, so the relevant current scientific evidence. But we also need to look at critical thinking. Remember, it's not just what your neighbors are doing. It's not just professional consensus. It's looking at what your neighbors are doing, seeing if what they're doing is the right thing to do, and are they getting the results that they should be getting. When Susan Helling went to her ophthalmologist in 1975, complaining of eye irritation and eye tearing and eye pain, her ophthalmologist gave her some drops, told her it was her contacts, and told her to come back in 2 weeks if she wasn't feeling better. So in 2 weeks, she comes back. She's not feeling better. He says, keep using the drops. 3 weeks later, she's ultimately diagnosed with wide-angle glaucoma at the age of 32 and sues her original ophthalmologist, who says she was 32 years old. We don't give glaucoma tests to patients who are 32 years old. The court, however, said that despite the fact that professional standards didn't require you to give her this exam, it would have been reasonably prudent, using this new standard of reasonably prudence based upon her symptomology, to give her the glaucoma test. So again, critical thinking, looking at your patient, don't just doing what you think you need to do based upon fixed guidelines if there are other things telling you that maybe you should look further. And the third component of the Sackett model is the patient. So we know that especially with respect to vascular devices, it's important to get the input of the patient with respect to device selection, device placement, device maintenance. And we know that when we bring the patient in with something we call shared decision making, not only do our costs go down, not only do our liabilities go down, but the number of tests go down because the patient is involved. And in addition, patient satisfaction goes up. So we not only need to educate the patient, but we need to educate the clinician and educate the clinician to educate the patient. So the moral of this legal story is, don't just keep doing what you're doing if it's not working just because everyone else is doing it, because you're risking potential liability. And as you've now seen, defendants have been found liable for malpractice for the failure to adopt new technologies and procedures, even when everyone else isn't doing it. Because if the guidelines are outdated, as many of them happen to be, compliance with them is not going to get you off the hook. So clinicians have got to rely on current scientific evidence even before it's regarded as prevailing custom. There is a duty to stay abreast. There is a duty to learn about small evidence-based studies, which is why hopefully most of you will be coming to the conference in Las Vegas. This is why it's important to go to conferences and go out on the conference floor and see what all these great new technologies and companies are offering. Because if the technology is out there and you fail to use it, there can be problems, not only for your patients, but potential liability problems. So it's very important for you and required of you to stay up with technology. And for those of you who may have heard Matt Ostroff and I present years ago at AVA, we talked about this concept of off-label usage. This concept of keeping current is what off-label usage is all about. The FDA didn't want to regulate the practice of medicine. They didn't want to get involved, but more importantly, the reason they came up with off-label usage is because they couldn't keep current. They knew that changes in technology, products, practice were happening so quickly that it would have been impossible for a government organization to stay current. So they came up with this concept of the learned intermediary doctrine, which I talked about. And that concept is, once the manufacturer has imparted all of the relevant information about a product or a practice to you as a learned clinician, then it's up to you to figure out, is that good for my patient? Should I use this for my patient? And we know that in the areas of oncology, pediatrics, psychology, off-label usage has had tremendous benefits. And you don't even need informed consent from your patient in most states to employ off-label usage. And as long as that product is used in the best interest of the patient without fraudulent intent, that it's being successfully used by other similarly situated practitioners in the field, that the urgency outweighs any of the risks and that the benefit outweighs any of the risks, then you need to consider using products off-label. Now, that's not to say that if a product is available, an on-label usage is available, it's better to use the product on-label. But don't negate off-label usage if there's no on-label product that's suitable. And please don't confuse off-label usage with product alteration, such as cutting a PIC and making it into a midline. That's not off-label usage. That's product alteration, and can get you into a lot of potential issues. And this also ties in with the importance of implementing technology. In many of my presentations, I use this slide. Technology, when it's readily available, reasonably reliable, you're competent to use it, and it won't harm the patient, then you've got to use it. This is all about keeping current. This is all about the fact that medical malpractice standards change not because of changes in technology, not because of changes in the law, but because of changes in technology. This is where keeping current is so important. The law isn't changing. The technology around the practice is changing, which is why you need to keep current, which is why you need to look for new products or practices that can solve our issues around catheters. And the only time that new technology shouldn't be implemented is if it in fact has potential new clinical risks to your patient, or changes the underlying process of care, or there's a requirement for informed consent that you can't get, or it requires some special training or expertise or competency that you don't have, or maintenance that can't be provided, or maybe the cost is so prohibitive that it just isn't practical. But outside of those reasons, technology needs to be used and implemented, and the failure to do so can set you up for malpractice. And I always talk about the example of the patient who's been stuck 6, 7, 8 times, and there's an ultrasound machine sitting in the corner which the clinician has been trained on and is competent to use, but fails to use that ultrasound machine to insert the catheter. That's when you're setting yourself up for potential problems. So what's all this talk about the glue? What's all this talk about tissue adhesive? Can tissue adhesive solve some of our problems? Does it meet the evidence-based criteria as a viable solution for keeping our catheters in place longer and reducing adverse events? Well, as I mentioned before, this is cyanoacrylate. It's crazy glue. It's Dermabond. It's stuff that's been around for long periods of time. It's been used for wound closure in orthopedic, facial, cranial, spinal surgeries. When I was a kid and had a hernia operation, they used it on me. But the important thing for vascular people is that it has been recently approved by the FDA for vascular access. And the beauty of this product is not only is it bactericidal, but it's also hemostatic, so it prevents that oozing that often occurs. It protects the integrity of the skin. It keeps the micromotion or the pistoning of our catheters to a minimum, and actually it, probably prevents them from moving at all, reduces unplanned dressing changes, and maybe most importantly, it's cheap and it's easy to use. And while it reduces or prevents oozing, it's important to realize that the glue can't be used on an active or current bleeder, but it certainly can be used on oozing that takes place after catheter insertion. So what do the guidelines say? Well, the guidelines say that cyanoacrylate for securement plus standard transparent dressings have shown a slight trend towards reduction in catheter failure, but larger trials are needed. Now remember, these are the 16 guidelines that I was a reviewer on, which means they were really written in 14 and 15. So the larger trials at that time weren't yet out there. The year before the guidelines came out, Marsh did a pilot randomized control trial comparing tissue adhesive with sutureless securement devices, bordered polyurethane dressings and standard polyurethane dressings. And you can see that even in this very small study, that the tissue adhesive did significantly better with respect to catheter failure than the other types of dressings. The problem here is that there are 4 adverse events also reported in this study. The reason for those 4 adverse events is that this was using the older version of cyanoacrylate. This was using a version that was called the N-butyl, or the 4-carbon version. The newer version, which is the 2-octyl or 8-carbon version, does away with a lot of these problems. So when they did the surgery on me and they put this cyanoacrylate on me, it was the older version, and the older version was very brittle. It peeled off very quickly. There were some issues with it. But the newer version is much more flexible. it's water resistant, it's less cytotoxic, and maybe most importantly, it's effective not only against Staph aureus, so not only against gram positives, but effective against gram negatives, yeast, and fungi as well. And it pretty much dries on contact when it hits the skin. So the year later, Bugden did another small RCT, comparing again tissue adhesive with a standard bordered polyurethane dressing and tape. And here he shows again, looking at catheter failure, dislodgement, phlebitis, and occlusion, that tissue adhesive, again, did pretty much substantially better, especially with respect to catheter failure, than the other type of dressing, and also did better with respect to phlebitis and occlusion. But again, these are small studies. These are those small RCTs. Now, it's not that you shouldn't use these, and I think I've already talked about the legal rationale behind why you can look at these studies and why you should look at them. But then last year, our friends over in Australia did a large RCT using tissue adhesive and comparing it with 3 other dressing and securement methods for over 1,800 patients. And the goal from Claire Ricard's group was to identify the optimum dressing securement method for PIVs. They wanted to find the dressing and securement method that was most conducive to a favorable outcome. And what did they find? Well, looking at the 3 other dressing types compared with the tissue adhesive with the standard polyurethane dressing, they found again that the tissue adhesive with respect to catheter failure, with respect to occlusion, with respect to dislodgement, did better than the 3 other types of dressing changes. And again, between 0.5 and 9% better. So not huge percentages with respect to statistics. But what do these numbers really mean? And we're going to go back to the Robert Helm article. Do you remember I told you that Helm talked about the huge number of PIVs, so that even though the infection incidence at 0.2% was low, that translates into huge numbers. Well, it's the same thing here with tissue adhesive. With respect to catheter failure, it was only 8 or 9% better, right? But in a typical 250-bed hospital with 100,000 insertions a year, what does that 8 or 9% mean? It means 8 to 9,000 fewer catheters each year not failing using the tissue adhesive. On the worldwide stage, it could mean 80 to 90 million additional catheters not failing. With respect to occlusion, the same thing. Small percentages, big numbers. 3 to 7,000 catheters each year not having occlusions. 30 to 70 million on the world stage not having occlusions. With respect to dislodgements, the percentages are even less, 0.5 to 1%, almost seems like nothing. But remember, the infection rate of 0.2% from Helm was 500,000 infections. 0.5% in your hospital could be 500 fewer dislodgements. And we know that it's not only dislodgements, it's infiltrations, it's extravasations, it's occlusions, and it's all that other nasty stuff that results when you have a dislodgement. And the other beauty of this product is it's cheap. Actually, it's not $5. It went up since I made this presentation. It's $6, but it's still a drop in the bucket. So I like to think of this as, what are the costs of not adding tissue adhesive? 9,000 fewer failures, 7,000 fewer occlusions, 1,000 fewer dislodgements. And you're decreasing the risk of CRBSIs, which can be extremely costly. An average of, some studies say, $56,000 per infection, plus a 7 to 10 day increased length of stay. Plus, you've got all those penalties under the Deficit Reduction Act and Affordable Care Act that I used to talk about when I gave those presentations. But what did Claire Ricard conclude? What did Avatar conclude? Well, unfortunately, because this is the real world and they're statisticians and they need to stick to the requirements, they had to conclude that none of the interventions significantly reduced PIV failure. But remember, even if the percentages are small and may not meet statistical requirements for paper publishing, the numbers when it comes to PIVs are huge. They did agree that the occlusion rate with the tissue adhesive was significantly lower. They did agree that the tissue adhesive group had no infections. Very, very important. They also said that securement bundles might be very important to develop in reducing PIV failures, and that improved dressings and securement is needed to prevent many PIV complications, but that the optimal method remains elusive. And so all they could really conclude was that the cost per patient using the standard polyurethane dressing alone was significantly less than the other three. So when they came up with this conclusion, I wasn't particularly happy because that wasn't how I read the study. So I actually talked to Claire Ricard about this and said, look, I want to say something else. What will you allow me to say, or what will you agree that I can say with respect to the SAVE study, which I believe was a great study? So what Claire allows me to say is, while a solution to prevent 100% of PIV catheter failures remains elusive, based upon the statistics, the SAVE study did indicate that a clear trend that of the 4 dressing and securement options evaluated under this study, that the tissue adhesive was superior in the prevention of occlusion, dislodgement, and catheter failure. And when we look at the numbers, and up to 69% of these catheters failing, that could be very, very significant. And when you factor in the reduced infections that occur when you use tissue adhesive, the cost differential between just the standard polyurethane dressing and adding the tissue adhesive came out to only 55 Australian cents more per patient. And what's really beautiful about this is that 55 Australian cents is only 40 American cents, so even less. And remember, even though we're just talking about this with respect to peripheral catheters, this little glue, this tissue adhesive, is applicable to arterial catheters, to PICS, to midlines, to central lines, to any type of catheter. Mauro Pittaruti uses the glue almost exclusively in Italy. He's told me that the glue has essentially eliminated his post-insertion oozing, and it's reduced his CRBSIs tenfold. And there are more randomized control trials going on with this product all the time. Trish Clyden at Cincinnati Children's recently published a pilot RCT on using tissue adhesive for PICS in pediatrics. And Amanda Ullman in Australia published another pilot RCT on using tissue adhesive for tunneled central lines in pediatrics. So more and more studies are going on, and it's simple to use. It's a drop under the catheter hub, it's a drop under the insertion at the insertion site, and you're good to go. So when I look at the legal kind of requirements of this product and whether they meet them or they don't meet them, number one, it's supported by the guidelines. The guidelines did say larger trials are needed, but we're getting them now. And it's being supported by the evidence that's coming out. We've got the FDA approval for this product. The product has been improved from the original N-butyl blend, and it's now effective against a variety of gram-negative, gram-positive yeast and fungi. So a broad bactericidal property to this product. It keeps the catheter from moving. It prevents that micro motion of the catheter. In addition to that, it's hemostatic, so that oozing is stopped at the insertion site. And it helps us meet the standard of care with respect to reducing unplanned dressing changes and protecting the integrity of the skin. Two of the factors we talked about before with respect to meeting the standard of care. And the stuff comes off easily. So after 4 to 7 days, it sloughs off by itself. So we also don't have to worry about MARSI. And as I mentioned before, it's cheap. So when I look at the legal criteria around this product, the first thing that you're going to be asked, or that comes out on a potential malpractice claim, is the question of, was the HAI preventable? Because remember, as I said years ago in one of my first AVA presentations, with preventability comes liability. Very, very important. So the first thing we're going to look at is, hey, is there some available product, practice, technology out there that could have prevented the adverse event with minimal risk, liability, cost, and training? And if so, why didn't you use it? Can anyone legally justify a catheter to fail when there are products available out there that meet the evidence-based criteria and have been proven to reduce adverse events? How much failure do you need to inaugurate change in your facility? What if you were the one with the infection? Would you have given over that 55 or 40 American cents to get rid of the infection? And remember, the burden is on you and on your facility to prove that you have done everything you can to protect the patient. So the questions to ask: can PIV failure constitute a breach of the standard of care? And can it be considered negligence, especially when there are available products and practices out there that could have reduced or even eliminated the adverse event? Keep in mind, malpractice standards change not because of changes in the law, but because of changes in technology. So why isn't anybody looking at PIV failures? Is it because we think they're safe? We're not looking at them as a source of infection, yet a study just out last month by Tatsuno entitled Clinical Features of Bloodstream Infections Associated with Peripheral versus Central Catheters states that PIVs are not safer than central lines with respect to bloodstream infections. Therefore, it's necessary to use similar precautions relevant to central venous catheter use in order to avoid problems. We're going to start seeing litigation around this. One of the problems has been that patients don't get it. They don't know that pain isn't normal, as we know. So they don't understand the cascading set of adverse events that can happen if catheters start to move. But this is going to change. And as I said before, we've got evidence for other catheters as well. And the stuff comes off easy. We've got more and more studies coming out, all proving the fact that using tissue adhesive helps you to meet the standard of care. And then, before I conclude, we're going to get back to little Emmy Gunther. I can tell you, when these photos show up in court, no matter how good your defense is, they're almost impossible to defend these photos. You can't defend the photo of Emmy Gunther's hand on the left-hand side. To give you an idea of how difficult it is to defend this case, remember, this is Winnipeg. I don't know if there are Canadians on the call, but for those of you in Canada, you know this. People don't file malpractice claims in Canada. The reason for that is when you're a doctor in Canada, regardless of whether you're good or bad, you pay the same amount for your medical malpractice insurance every year. And then the Canadian Medical Protective Association, better known as the CMPA, reimburses you for 83% of those costs. And what happens then is this organization, this CMPA, has become an extremely powerful organization to the extent that people are afraid to file malpractice actions in Canada because you can't win. The CMPA is willing to spend $1 million on a case that's worth $1,000 because they've got the funds, they've got the resources. And in Canada, they also have something called losing party pays, meaning that if you bring the lawsuit and you lose, you got to pay all the costs. So lawsuits are not filed for medical malpractice in Canada. To give you an idea of how few of them are filed, in the United States alone in 2012, there were over 12,000 judgments for malpractice. Between 2005 and 2010 in the entire country of Canada, there were only 116 malpractice judgments in those 5 years. But Emmy Gunther's parents are suing. They're suing for malpractice. They're suing for failure to meet the standard of care around this extravasation. So, some final thoughts. Tissue adhesive benefits. Secures the catheter. Bactericidal. Hemostatic. Assists you in reducing or assists you in maintaining the integrity of the skin, protects the skin integrity, reduces unplanned dressing changes, which we know are bad, and helps you to meet the standard of care around the PIV. So we know that our PIVs are failing. There are many reasons for that. We know that many of our catheters are failing. Stability and securement, even as proven by our poll, is certainly one of the reasons around why PIVs are failing. We know that we've got to keep current. And in order to keep current, we've got to be aware of the new products and practices and technologies that are out there, because to the extent that we can reduce adverse events, we are required to do that. If there's some product, practice, or technology that's out there that could have reduced the adverse event and you failed to use it, that's when you set yourself up for liability. And as Helm recently said in his updated article, if trauma is viewed as any force that shifts the peripheral catheter within the vein, causing tissue injury or mechanical loss of the catheter, this points to the fact that improved catheter stabilization and securement is necessary to eliminate traumatic movement. But such stabilization must be introduced into the care and maintenance practices in a way that is clinically simple, highly reproducible, and cost-effective. Everything that tissue adhesive is. Simple, highly reproducible, and cost-effective. Efforts are underway as new products are being developed. And what I say is, you need to consider that one of these new products, which isn't really even so new, is tissue adhesive, which should be considered a primary intervention to prevent premature PIV failure and help you to meet the evidence-based standard of care, which is so desperately needed to help you improve your product and improve the outcomes of your patients and result in a better quality of care. Thank you.
Russ, that was awesome. Thank you so much. Now we have time for some questions, and we do have a few right now. If any of you out there do have a few questions you'd like to ask Russ, what is the best? This is a question we have from Valerie. What is the best way to go about starting a new standard of vascular access and using ultrasound guided technique, especially for the pediatric setting, difficult sticks in a facility that does not currently practice it?
Well, first of all, it depends upon what your hospital policies and procedures say. I mean, you've got to comply, first of all, with your hospital policies and procedures. But if, in fact, you're aware of issues or adverse events that are occurring, then one of the first things, and question I always get asked is, who do we talk to about this? And one of the first things I recommend is that you talk to risk management about it. And if, in fact, you are either not complying with your policies and procedures, or you have policies and procedures in place in your facility that are outdated or may not be taking into consideration the latest and greatest that's out there, not only with respect to change of catheters, but with respect to pediatrics as well, with respect to ultrasound guided insertion, then you need to make them aware of this and that adverse events are actually happening, and there are solutions out there that can be put into place that can reduce the adverse events. And then you also need to make them aware that there is potential liability around this. So if we're exceeding the number of sticks that are recommended in the guideline, and there are methodologies and technologies that can help us to meet that standard of care, we need to be using them.
Lee, I'm going to start with, I agree with you. Says, no question, just a comment. PIVs need to be placed by experts who do this every day using a bundled approach. What do you think, Russ?
I think that would be great. And I know the problems with that. I think one of the problems is we place so many PIVs that it's very hard to comply with things like maximal sterile precautions. It's very hard to comply with things like bundles. But it's the right thing to do. It's the legally defensible thing to do. And I think that the more organizations and facilities that develop PIV bundles, the less likely we're going to see adverse events. And my own feeling has been that our large number of HAIs has been really due to this under-recognized risk. The PIV is actually the source of many of these infections.
Next question for you. Is tissue adhesive appropriate for PIVs that are to be left indwelling for less than 24 hours, like in an outpatient setting? So
that's a great question, and probably the tissue adhesive people would be best off to answer this, although I will tell you that if you do need to remove the tissue adhesive prior to its natural degradation, which would be 4 to 7 days, then you can use an adhesive remover. And there are many of those products on the market. I can't mention any names, but I'm sure most of you know who they are. And, you know, so it can be used. So if you've got, for example, a potentially problematic catheter placement where you feel there's going to be a lot of potential motion and potential damage and injury, then I would say that yes, it certainly could be used. And keep in mind that there are ways to get the cyanoacrylate off prior to this natural 4 to 7 day attenuation period.
And part of that, Russ, is it's going to slough, and basically letting the skin do its own job and having the glue come off naturally is better than trying to scrub it off, which could do some skin damage. So it's going to come off naturally. So it doesn't even need to happen. In that situation, I think it is appropriate if it's especially if it's part of a bundle. We do have a question that I'm going to try to take a stab at because it's respondent said, no, forget about it. I can't put it into words. But the question is not on PIV, but the use of biopatch. And I'm going to guess that part of the question is, do you need a biopatch if you're using glue?
Oh, so do you want, well, I know, for example, that both CHG and biopatch are compatible with the glue.
Next question is the product difficult to remove with transparent dressing during dressing changes and prevent line migration? And I'll take that one too for you, Russ. It's not. It is not difficult to remove. And again, you don't remove the glue per se. It stays on the skin. It's very much like a second skin. That's not an issue. Is there criteria in using this glue with neonates, such as minimal gestation age or weight? And no, there are no restrictions. We have a recent increase in CLABSI. Our vascular access team used to do all PIV insertions, but now they have given this back to floor nurses, and they are not meeting our standards. We are only called for difficult sticks. Could the increase of CLABSI actually be originating from prior PIVs introducing staph, yeast, and fungi? We're working really hard to reduce infection resulting from vascular access.
That's a clinical question, I believe, Judy.
It is, and it could. If anyone is not meeting the standard, and I'm not sure how high your standards are, likely high, and I appreciate that. But if they're not reaching the standard to put these in aseptically, if not sterilely, then they shouldn't be doing it. There's no panacea to fix PIV failure. We have to do it all right. Remember, the latest studies stated that most IV failures happen in 36 hours. So yes, it would be important. I think we're going back to the other question about if it's less than 24 hours, should we be using the tissue adhesive? So if we have most of our failures in the first 36 hours, then it appears that based on a 36-hour, your first slide showing results of tissue adhesive in comparison to the other products showed having 4 adverse events, and the others were all 0. Can you elaborate on what those adverse events were?
I believe, I need to look at the study again, but I believe the adverse events were catheter failure due to the fact that the older version of the cyanoacrylate was very brittle and therefore didn't secure and stabilize the catheter as well as the newer version, which is more flexible, allows bending without becoming brittle, thereby securing the catheter to a much better extent. So I'm not sure what the specific adverse events were, but I'm pretty sure it was the result of catheter movement using the older version of the cyanoacrylate.
Regarding allergic reaction rate with this glue. And I have not heard of a lot of, or any, I haven't heard of it. I'm sure it's possible. Does this product replace skin prep prior to dressing application? No, it does not. It does a lot of goodness once it's on, as in entrapping bacteria, not letting it migrate, and also making it so they can't get down the hole, so to speak. but it does not replace appropriate skin prep. Next question, how often does a PIV dressing need to be changed when tissue adhesive is used? Normal. That doesn't affect it whatsoever. So every 7 days in PRN. Does the adhesive cause degeneration of different type of catheters? That answer is no as well. It's been tested against many. And last question we have right now. Is it difficult to remove just the dressing for a dressing change if you're using tissue adhesive? Does the adhesive stick to the dressing, making it difficult to remove? No, it doesn't. That's pretty much the answer. It doesn't. Okay, well, Russ, thank you so much. This was wonderful. Thanks so much.
Thank you, Judy.
Bye, guys.